Hello, my name is Dan Sieczkiewicz. I'm a senior physical therapist at the Boston University Physical Therapy Center, as well as an instructor in BU's DPT program and BU's fellowship program in orthopedic manual physical therapy. I'd like to speak with you today about applying the optimal theory of motor learning into orthopedic clinical practice and share some of the growth we've gone through at our clinic to really integrate this into practice. So our objectives for this recording would be to first describe what the optimal theory of motor learning is, provide examples of common errors made during clinical and patient interactions. And I say errors because I couldn't find a better word for it. We were and still are guilty of these mistakes, but to a much lesser extent now because of how we've applied the optimal theory to practice. I'll then suggest some alternative strategies based on motor learning principles. And as we go through this, we'll relate some of these strategies to familiar clinical situations. So the optimal theory of motor learning, optimal stands for optimizing performance through intrinsic motivation and attention for learning. And the difference between learning and performance is important here in that performance is in the moment, learning being that performance is maintained after a retention test. So most theories of motor learning were siloed into distinct scientific disciplines. So the optimal theory tends to combine these approaches in an attempt for a unified theory of motor learning. So it draws on disciplines such as behavioral sciences, social cognitive sciences, and neurophysiology. So pictured here is a visual representation of the optimal theory. The two main tenets of the optimal theory are motivation and attention, and you can see them here on the left-hand side of this visual. It suggests that we'll improve motivation to learn by promoting learner autonomy and also enhancing the learner's expectations. With respect to attention, an external focus centered on the task rather than the individual performing the task will improve motor performance and longer term have a positive impact on learning. And this improved performance and improved learning then has the tendency to improve the learner's expectations for further learning. We'll discuss in more detail the motivational aspects of learning, and we'll start with enhancing expectancies. There are many ways to enhance learner expectancies, including providing positive feedback, providing social comparative feedback, self-modeling, adjusting the perceived task difficulty, and also helping to improve conceptions of ability. And we'll go through each one of these things here. So let's start with providing positive feedback. A common mistake we make is intervening to fix the movement pattern after it's not performed correctly. And what this results in is us providing feedback to the learner after bad trials. The optimal theory suggests that we provide feedback after good trials. And this is shown to improve motivation to perform the task again in the future, improves learning, improves confidence and competence of the learner, and also improves the learner's self-efficacy. So providing social comparative feedback, a common mistake is that we either don't do this or we provide negative feedback on one's performance relative to others. Things that we might say is, this usually works for most people, I'm not sure why it's not working for you, or it should be getting better. A solution to this would be providing positive social comparative feedback. And yes, even if it is not true. When we do this, however, we have to consider safety or risk, of course. So for example, if a patient's gait pattern places them at a high fall risk, we need to be upfront about that to prevent an undesirable event. But if it's incidental, even providing false positive social comparative feedback can improve satisfaction and motivation to learn. And experimentally in a group of runners who were told that their running form looked really good, better than most people, their running efficiency improved, and their perceived effort at a given workload was reduced. So things we might say to our patients would be, you're doing better at this than most people at this stage of your recovery. All right, and when we're doing this, though, of course, I can't stress enough that we have to consider the safety and risk in doing so. Self-modeling is difficult to achieve in the clinic. Experimentally, they've edited videos showing the patient or learner performing the task well. Even if they didn't do it well, they edited video to make it look good. And this was shown to enhance learning, again, measured by a retention test, improve satisfaction of the learner, and improve intrinsic motivation of the learner. So a solution for this that we can execute on in the clinic would be, with permission, using a patient's device to film them performing a good repetition or a good movement pattern. For example, we could have a patient who would say, I just feel like every time I squat, it looks terrible. So if we are able to catch them performing a good repetition, you can show them that the squatting actually looks quite good, better than most maybe. And this is helpful to create dissonance between how the patient learner feels versus what they see on film. So adjusting perceived task difficulty. A common mistake we might make clinically is introducing an exercise or movement pattern as being difficult. So for example, we might say something like, this is going to be really hard. And this has an impact on motivation and the expectation of how the exercise will go. A solution to this would be, when instructing an exercise, you use language that promotes success. So something like, active people like you typically do well on this task. This will help improve self-efficacy, improve their expectation for the task, and improve their motivation to learn the task. In doing this, however, we may set ourselves up and the learner for failure, which brings me to the next slide in mistake number 2. So if we're going to say that people like you typically do well on this task, we should probably make sure that they're doing well on that task. So common mistake number 2 is making the exercise too hard or defining success too conservatively. So a solution for this would be, make the goal of the task more achievable, or change the definition of success. So experimentally, golf putting with a large circle around the cup versus a small circle around the cup, and asking the putter to try to get the ball within the circle around the cup, they made the definition of success more liberal, and in doing so, increased the chance of success, and those who had the larger circle around the cup performed better on a retention test of putting. Similarly, using an illusion, so a golf cup surrounded by very small circles, which makes the cup look bigger, versus the cup surrounded by very large circles, which makes the cup look smaller, changed the perceived task difficulty, and those who thought it was going to be easier, so those with the smaller circles around the cup, were better at a retention test for putting. Clinically, a common instruction for cervical proprioception exercises, for example, would be, I want you to maintain the laser on the bullseye. And we'll talk about the phrase, I want you to, a little bit later. And this is quite challenging. To maintain that little light on the bullseye is quite challenging for most people, and can have a negative impact on motor learning if the learner is not able to achieve the goal of that task. So instead, saying something like, see if you can maintain the laser within the green circle. You made the definition of success more liberal, and there's an increased chance that the learner will actually achieve that. And lastly, with enhancing expectancies, improving one's conception of ability. So a common mistake we'll make clinically is providing instructions or feedback that facilitate a fixed mindset versus a growth mindset. So an example of this type of instruction would be, let's see how well you can balance. And when we assess balance, if it's not good, we might say that you have poor balance. This can be threatening to the learner's self, And failure at the task suggests that they have an inherent lack of ability to, in this case, balance. So instead, we want to make sure we're facilitating a growth mindset. So a growth mindset instruction would be something like balance is a skill that gets better with practice. Let's see where we need to start practicing. The feedback, when the learner is training in balance and the patient is training in balance, if they have a good repetition, we say that was a good repetition. So we want to have the focus be on the task rather than the person performing the task. So even if they perform well, we don't want to say, oh, you have good balance. We want to call attention to, oh, that was a good repetition. So when we do this, it decreases the threat of the task, and it improves the motivation to learn the task. Another example of just in general of a fixed mindset versus a growth mindset. Oftentimes I'll hear patients with low back pain coming in with a fixed mindset saying something like, I have a bad back. And this suggests that their back is inherently bad and will always be bad. Somebody with a growth mindset might say instead, I'm having an episode of low back pain. So you can see the difference between the fixed mindset and the growth mindset. And we want to make sure that we're facilitating a growth mindset, that these things can be learned and they're not inherent. So lastly, for our motivational factors on learning, let's discuss autonomy. So autonomy can be promoted according to the optimal theory in 3 ways. And this is where we can make a lot of improvement in our communication with patients, and pretty quickly at that. First, we want to try to provide the patient with some control over the practice conditions. A common mistake that we make would be that we as the clinicians control the practice conditions 100%. Things like, I want you to do 3 sets of 10, or use this pole to help you balance, or saying, here, watch me do it. That's using controlling language. Instead, we want to allow the patient to have some control over their own practice conditions. How many reps do you think you can do? How do we know that 3 sets of 10 is a good rep range, right? So maybe asking the patients, how many of these do you think you can do? And if they can do way more than we want them to, then we know that that exercise is too easy. But starting off with, how many reps do you think you can do? Or during a balance exercise, this pole is here if you feel like you need it to help with balance. So it's up to the patient whether or not they decide to use that pole for balance. Let me know if you'd like a demonstration. Some patients may not feel like they need a demonstration. Why should we jump in right away and provide that? So let me know if you'd like a demonstration rather than demonstrating right away. I alluded to this a little bit earlier. This is one of my favorites. That Post-it note you see in the picture on the right-hand side was hanging in the staff area of our treatment floor until we broke our habit of saying this. And I'll oftentimes hear personal trainers in the gym or other PTs doing the double "I want you to." And they say something like, so what I want you to do is I want you to, followed by whatever it is they would like that person to do. So that's a common mistake that we make. And the whole "I want you to" phrase is very much using controlling instructional language. What we want to do is use language that supports autonomy. So saying things like, see if you can, do you think you can, rather than I want you to. So that way, if and when the learner is successful in achieving that task, it's because they did it and they figured it out, rather than that you wanted them to do it. All right, so there's a subtle but important difference there. And I'm happy to report that Post-it note is no longer necessary in our clinic, but it took us a while to get there. It's a very, very, very tempting thing to want to say, but it's something that you can choose to work on, straight away. And having an accountability buddy or a Post-it note is certainly helpful to remind you. Also, allowing the patient to make incidental choices. So a common mistake is telling our patient what to do and when to do it. I want you to do squats, then lunges, then step-ups. Use this green TheraBand for your clamshells. Warm up on the bike. So rather than us as the clinicians making these choices for our patients, allow our patient to make these choices, but within the plan of care that you've developed. If we provide our patients with too much autonomy, it sometimes comes off as we don't know what to do. We're not sure what to do, or we don't have a plan. So within the plan that you have, provide some choice, especially if they're incidental choices. So things like, would you like to start with squats, lunges, or step-ups? Each exercise has a similar goal, similar level of difficulty. So if our patient has a preference on the order that they do them in, we should allow them to express that preference. Do you want to use the green TheraBand or the red TheraBand? Not a lot of difference between a green TheraBand and a red TheraBand. So if we offer our patient that choice, they're taking some autonomy, and that can improve learning. When it comes to warming up on a piece of cardio equipment, if we're not dealing with, say, a lumbar patient who has a directional preference, or a lower extremity patient who shouldn't be on one piece of equipment or the other, if the choice is incidental, we should say something like, what piece of cardio equipment would you like to warm up on? Patients oftentimes have preference, and we should be able to allow them to express that preference. Something as incidental as allowing them to pick the treatment table that they go to, and I'll meet you over there, rather than saying, you see that table next to the wall, go over there and I'll meet you there. Patients sometimes even have an area of the clinic that they prefer to be in. And we don't know unless we ask or provide them with that autonomy. And that can have a very positive impact on learning conditions. Experimentally, kickboxers who are able to select their combinations of punches and kicks during practice resulted in increased power output of those punches and kicks. And golfers who were able to select the color of their ball improved a putting task with respect to learning on a retention test. So allowing patients to have these seemingly incidental choices can be extremely valuable for learning. So now let's shift more towards the attentional aspects of motor learning. More specifically, how we can provide an external focus of attention when our patients are practicing tasks. So let's first define external focus of attention. So an external focus of attention would be promoting knowledge of the result of a movement pattern, rather than providing our patients with knowledge of performance of how they performed that movement pattern. So in other words, the focus of attention should be on the result or the goal of the task, so knowledge of results, rather than on how they're performing the task. So we want to make sure we set up our exercises or set up our tasks so that the learner has to figure out how to achieve the desired result or the desired goal. We want to make sure we resist the urge to tell the learner how to perform the task. And I'll give an example of this on the next slide. So when we use knowledge of results rather than knowledge of performance, it's been shown to improve the following. So movement effectiveness, which might be balance or accuracy, movement efficiency, which might be things like force production, speed of movement, or endurance. It improves movement form, and it improves automaticity. So being able to recall that movement pattern independently and reproduce it on a retention test. So if we use these knowledge of results versus knowledge of performance through an external focus of attention, so taking the attention away from the learner and more onto the task, we can achieve improvement in all of those areas. All right, so here are a couple of common examples of how we might use an external focus of attention clinically. So the photo on the left is a hook-line marching exercise, and in the picture, the person is using a biofeedback stabilizer device under their lower back. So traditionally, to instruct in this exercise, we may have said something like, squeeze your abs and glutes to do a pelvic tilt so your back is flat against the floor. Keep your back flat on the floor while you lift your knee. Don't let your back arch. So all of those instructions are telling the patient how to do it, and it's all internally focused. So we're telling them what to do with each individual body part. And that is going to have an impact on learning negatively. So we've told that patient exactly how to do that exercise, rather than allowing that patient to figure out how to do the exercise, which would have a positive impact on learning. So instead, what I would suggest is saying something like, see how that needle reads 40 on the dial? Do you think you can keep that needle between 35 and 45 while you alternate lifting your legs? So the result of this is a learner trying to problem solve on how to maintain that needle within that range, rather than me telling them how to do it. The muscles that are going to be worked are the same, but this is going to promote learning, and the patient will be able to reproduce this task automatically, independently, without relying on me telling them how to perform it. The picture on the right, we oftentimes will use lasers in the clinic as an external focus. As an example, if we're seeing a dynamic knee valgus, for example, during a single leg squat or a lateral step down, rather than saying, don't let your knee drift inward, we would use the laser and say, do you think you can keep that laser tracking along that line? Now, to make sure that we are being consistent with enhancing expectancies, we can make that line as thick as we need to promote success and have a more liberal definition of success. What we've also done is use painter's tape along the wall, make two lines going straight up and down, and make the gap between the two lines more narrow for a harder exercise, or make the gap between the two pieces of tape wider to promote success when the learner is just starting off with the task. So these are great ways to provide an external focus of attention. And honestly, for me and for many of my colleagues, this has really helped us to simplify our practice. We're getting better results in terms of motor learning. We're turning patients into problem solvers. And it really cuts down on the number of different cues that you have to give your patient. It really comes down to one or two cues. Keep that laser, see if you can keep that laser between the two lines. See if you can keep that dial between 35 and 45. And that really, really simplifies your practice and cuts down on the number of different cues that you have to give, and really promotes learning, automaticity, problem solving on behalf of our patients. So in summary, use language that improves the learner's expectation of the task. So to do this, we want to provide feedback after good trials. Consider being more liberal with your definition of success, and make sure that we're facilitating a growth mindset. This task can be learned. You're not inherently good or bad at it. We want to promote learner autonomy. So allow our patients to make choices. Allow them to make choices on the number of sets, reps, the order that they do the exercise in, whether or not they use an assistive device during the exercise. Avoid the phrase, I want you to. Replace this with, see if you can, do you think you can? And making sure that we're taking the focus of attention off of internal aspects related to the learner, like what each body part is doing, and take that focus of attention externally on some goal that learner has to achieve in order to result in the desired movement pattern. This will turn them into problem solvers and improve their ability to recall that movement pattern independently. My advice moving forward, takes a while to break some of these habits, and even just starting with recognizing how often you're doing some of these things is a good place to start. So think about how you can change your communication with your patients, both for exercise instruction and feedback during exercises. There are a lot of aspects here that we can change to improve our practice. Take them one at a time. If we try to do each one of these things right away, we're going to be good at some of them and not good at others. So take one aspect at a time, try to master it or improve in that particular aspect, and then move on to another aspect. Having an accountability buddy or an accountability post-it note can be extremely helpful, especially if you work in an environment that's open and is facilitating a growth mindset. being held accountable can be extremely helpful and non-defensible as well. So I would highly recommend having an accountability buddy or post-it note. All right. Here's the reference for the optimal paper if you'd like to read it yourself. There are several other experimental examples of how some of these concepts have been used in sport and in other tasks that you can translate to your own clinical practice. Almost think of them as little vignettes that tell a nice story on how to apply the optimal theory. So here's the reference there for you. And lastly, thank you for your time. I hope you learned a little bit that you can translate into your clinical practice about how we communicate to promote motor learning. And also thank you for providing our students with high quality clinical experiences. Take care. Bye-bye.